Hi, are you an X-ray tech or an X-ray student who struggles with lateral knee X-rays? Do you often find that you're repeating them quite often? Can you tell the difference between whether it's over or under rotated? And if so, how do you fix it? Follow along. I'm going to share some helpful tips that's going to help you feel more comfortable and competent in your lateral knee X-ray positioning.
So let's do a quick recap of the knee anatomy. Here's the femur, the tibia, and the fibula. The tibia is the weight-bearing bone on the medial side of the body. The fibula is the non-weight-bearing bone on the lateral side of the body. Here's the patella. The flat superior part of the patella is the base, and the pointy distal part of the patella is the apex. Here we have the medial epicondyle and the medial condyle, and the lateral epicondyle and the lateral condyle.
So let's see the fastest way you can tell if your knee is rotated.
When positioning a patient for a lateral knee x-ray, we have them roll onto their affected side. We place the x-ray tube at an SID of 40 inches and a tube angle of 5 to 7 degrees cephalic. If you see the proximal tibiofibular joint space open on the x-ray, that usually means that the knee is over-rotated, while too much overlap of the proximal tibiofibular joint space can indicate under-rotation.
This single visual check can help save you time, repeats, and second guessing. Now let's talk about the most reliable anatomy clue that students often overlook.
You have the medial condyle and the lateral condyle. The lateral condyle will look flatter in appearance and will have a divot or a lateral notch. It's also smaller in appearance when compared to the more rounded, smoother portion of the medial condyle. In this projection, if you needed to correct anything, I would say correcting from anterior to posterior. So this is the anterior part, this is the posterior. So when we see the medial condyle sitting more posteriorly, it means that the patient is under-rotated. So you could rotate the patient up slightly to get these more superimposed. However, looking at this image, this isn't an image that I would actually repeat. I would call this diagnostic.
When it comes to lateral knee x-rays, rotation isn't the only problem. Tube angle is just as important.
In this example, we have both a lateral and an AP knee x-ray. When looking at knee x-rays, it's important to know what exactly you're looking at, how the patient is laying on the table, and how to identify whether the patient is over or under rotated, or if it is a normal diagnostic x-ray. So in this case, the femoral condyles we can see from anteriorly to posteriorly are superimposed. We can tell that there is not a whole lot of overlap between the proximal tibiofibular joint space, but the space isn't completely open either. Here we can identify the lateral condyle as this one here, smaller in appearance, and then the medial condyle that's sitting here. So from anteriorly to posteriorly, these are superimposed. However, whenever you see this space here, so this is part of the medial condyle, the larger of the condyles, sitting more inferiorly on this x-ray, and that's because the medial condyle typically sits more distal than the lateral. So in this image, you have the proximal portion, distal, lateral, and medial. And you can see here that this condyle is sitting a lot closer than the lateral side. So when you rotate that patient into a lateral position, if you do not use a cephalic angle, then you're going to see the medial condyle sitting more inferiorly on the x-ray. So to compensate for that, we add 5 to 7 degree cephalic angle to superimpose the condyles from superiorly to inferiorly. If the medial condyle appears lower when looking superiorly to inferiorly, you need more cephalic angle. If the medial condyle appears higher than the lateral, you likely have too much tube angle and need to reduce it, or even shoot perpendicular depending on the patient's anatomy.
So understanding why you angle the x-ray tube, not just that you angle the x-ray tube, puts you in control of the image instead of relying on memorization. So here's how to fix most lateral knee x-rays in seconds.
Most positioning errors come from patient rotation, not the tube. If your image is over-rotated, you will often notice that the patient's heel is raised up. Gently bring the knee back towards the table to put the anatomy into a true lateral position. If it is under-rotated, you'll notice that the patient's toes will be elevated. Rotate the knee more laterally onto the affected side to put the anatomy into a true lateral position.
Small movements, just a few centimeters, can make a huge difference. You don't need to make drastic adjustments, just intentional ones. This is how X-ray techs move efficiently. Here's a simple checklist on how to help you with positioning lateral knee X-rays.
First, are the femoral condyles superimposed? In this example, yes, the femoral condyles are superimposed. Second, is the tibia and fibula overlapping appropriately? In this example, no, the proximal tibiofibular joint space is not overlapping appropriately. You can tell that the patient is over-rotated and that there is open space between the proximal tibiofibular joint space. Third, can I identify the lateral notch? In this lateral knee X-ray, you can tell the difference between the lateral condyle and the medial condyle by looking for the lateral notch. The lateral notch is seen on the lateral condyle of the femur and is also smaller and flatter in appearance when compared to the larger, more rounded, smoother surface of the medial condyle. Fourth, does my tube angle match what I'm seeing? In this lateral knee X-ray, you can tell that the patient is under-rotated. You can determine this by looking at the medial condyle that sits more posteriorly, in addition to the superimposition of the proximal tibiofibular joint space. Also, we will need to use a cephalic angle of 5 to 7 degrees to help superimpose the femoral condyles from superiorly to inferiorly. The more lateral knees you analyze this way, the faster and more confident you'll become.
Stop thinking in terms of right or wrong and start thinking in terms of cause and correction. Master that and lateral knees won't intimidate you anymore. They'll make sense. If this video helped you feel more confident in your lateral X-ray knee positioning, subscribe for easy to follow X-ray tips and real image critique. Let me know in the comments which view you struggle with the most. Master X-rays one at a time. Subscribe for weekly positioning tips. Thanks for watching. See you in the next video.